Hello, everyone. My name is Johanna Seitz, Holland, and I work as an instructor at the Psychiatry Neuroimaging Laboratory at Brigham and Women's Hospital and Harvard Medical School. I am really sad that I cannot be with you in person, but I'm also really honored that I get the chance to present some of the work we have been doing on relationships between white matter pathologies and clinical and cognitive variables. Before I start, I have nothing to disclose. Building on what my colleagues presented earlier, I will discuss our efforts to combine imaging findings with demographic, clinical, and cognitive data. First, I will briefly introduce our study rationale. Then, I will present findings from a study examining the effect of sex on healthy brain structure. Then I will show you our findings from a study examining the effects of sex and clinical variables such as illness duration, medication, or symptom severity on white matter structure in schizophrenia. Last, I will present our findings on cognitive deficits and their association with white matter structure in schizophrenia. And then I will conclude with some general remarks with limitations and future directions, which will hopefully give some discussion input. So as you have already heard, our study retrospectively combined data from 13 international sites, altogether over 1,000 individuals, 492 healthy individuals, and 597 individuals with schizophrenia, aged 14 to 65. And as you have already heard, it is particularly challenging to combine diffusion-weighted MRI data from different sites because the signal in diffusion MRI is dependent on the scanner and the sequence. Therefore, in the first step, my colleagues developed a harmonization algorithm. They applied this algorithm to the data and then extracted the diffusion measures for the whole brain and for the 14 main white matter fiber tracts. And as already presented, they then modeled brain structure across the lifespan and compared these changes with age, these trajectories between healthy individuals and individuals with schizophrenia. And I would like to talk a little more about how we relate these trajectories to demographic, clinical, and cognitive variables across the lifespan. What's important to keep in mind is for all analysis and results I'm presenting, we used fractional anisotropy, so FA, and not the previously introduced more specific free water measure. So first, we wanted to understand the effect of sex on brain structure a little better. And this is why we first conducted a study in the healthy individuals only. We again modeled the FA changes over age, the FA trajectories, which you can see here. This time, everyone is healthy, but we separated males from females. And what we found was that for 5 tracts displayed here, females demonstrated lower FA values. And all these tracts are part of the limbic system. They are important for emotion regulation and also memory. However, what I think is even more important is that we did not see any effects of sex for 9 of the 14 tracts. And also, even when looking at these 5 tracts, we saw a high overlap between males and females. And this is what's displayed in the graph here. So here, red means a tract looked more female, and and blue means a tract looked more male. And what you can see that for almost everyone, they had a mixture. So some tracts looked more female, some tracts looked more male. And there are only very few individuals which show all tracts male or all tracts female. Additionally, it's to note that even for these 5 tracts, while we see lower FA in females, the change with age, the trajectory, is the same for males and females. And this is why we decided to include sex in all our analysis, but not to model these FA changes with age separately for males and females. Next, we studied how the previously described FA abnormalities in schizophrenia relate to demographic and clinical abnormalities or variables. And we were specifically interested in age, in sex, age of onset, duration of illness, medication, symptom severity, and IQ. And we faced two main challenges. The first one is, if you think about age of onset, and duration of illness, these variables are highly related to each other. So age minus duration of illness is age of onset. And we decided to tackle this challenge by not looking at absolute FA values, but we used the healthy FA trajectories with age and then determined for each individual with schizophrenia how much they deviate from these healthy trajectories. What this is doing, it's basically correcting for the effects of healthy aging and then asking the question which variables are related to abnormal FA. The second challenge we faced was that we had to, similar to the imaging data, we had to combine the demographic and clinical data from the different sites. And this is pretty obvious for age, for sex, age of onset, duration of illness, also IQ. And luckily for medication, there are published and also validated norms to calculate chlorpromazine equivalent dosages. However, it was surprisingly difficult for symptom severity. So the different studies had used different questionnaires, and even between the two which were used the most often, which is the positive and negative symptom scale and the brief psychiatric rating scale, the overlap wasn't that much. So we evaluated all the items and the label definitions and then ended up only including 7 positive symptoms and 2 negative symptoms. And we also decided to transform the original scales to a 4-point scale, which is no symptoms, mild symptoms, moderate symptoms, and severe symptoms. So what were our main findings? First, we did not really see an effect of medication on brain structure. And second, and aligning with the previous findings, we found that for some tracts, a longer duration of illness was related to more white matter abnormalities. Interestingly, this was particularly pronounced in males, and it suggests a neuroprogressive or degenerative pathology. It also aligns with some clinical studies that suggested that males might be more vulnerable to the effects of chronic illness or chronic schizophrenia. We then calculated a structural equation model, which you can see here, to examine the association between the white matter structure and the symptom severity. And indeed, we found that more white matter abnormalities were related to more symptoms. And this was particularly true to positive symptoms. And interestingly, this association was mediated by IQ, specifically in females. So what does that mean? It means that in females, a higher IQ seems to be a protector against the adverse effects related to structural brain abnormalities. And this aligns with some previous studies which suggest the role of cognitive reserve, specifically in females, which is protective against the long-term effects of schizophrenia. We were quite interested in these IQ findings and decided that we wanted to look at cognition in a more refined way. And you can guess it. Again, the problem was that all the different studies had used different cognitive tests and measurements. And what we did here was that we first, for each individual different measurement, different study, we calculated T-scores. And we did so by using already published norms. And then we grouped all the different T-scores into 8 cognitive domains. And this is based on previous meta-analysis. And then we calculated for each individual a mean t-score for each domain. And as you can see here, individuals with schizophrenia are presented in red and healthy individuals are presented in green. And you see that individuals with schizophrenia demonstrated lower cognitive performance in all 8 domains, which were language, processing speed, vigilance, working memory, verbal memory, nonverbal memory, motor function, and executive function. And the effect sizes were medium to large. The effect size was the largest for processing speed. And it remained significant when controlling for the effects of IQ or years of education or both. When we looked at the effects of age and sex, we saw surprisingly few effects. So an older and a younger age were related to more vigilance impairments in individuals with schizophrenia than middle age. And we also found a sex effect on working memory. Male individuals with schizophrenia demonstrated more impairment than female individuals with schizophrenia. Medication had a mixed effect, so more medication was related to better processing speed, working memory, and executive functioning performance, but worse language performance. We then applied mediation models to explore the association between a diagnosis of schizophrenia, these cognitive deficits, and also whole brain white matter structure. And as displayed here, what we saw was that FA partially mediated the association between a diagnosis of schizophrenia and cognitive performance, specifically for language, processing speed, working memory, and nonverbal memory performance. And this is cross-sectional data, so we cannot determine causality, but it is a statistical causal model, and it suggests that a diagnosis of schizophrenia yields white matter impairment, which in turn translates into cognitive deficits. And given the pronounced role of processing speed in cognitive deficits, we also looked at an additional model. And what we found was that processing speed partially explained the association between a diagnosis of schizophrenia, white matter structure, and cognitive performance. So this model suggests that having schizophrenia yields to white matter abnormality, which then translates into slower processing speed, and which then translates into other cognitive deficits. And this highlights the crucial role of processing speed for schizophrenia. Taken together, our studies show that it is possible but challenging to retrospectively combine multi-site, multi-model data, and it is important to develop appropriate harmonization approaches. And they further highlight the critical role of white matter for the pathophysiology of schizophrenia. White matter abnormalities are present across a wide age range, and they are related to clinical presentation and also cognitive deficits. And we believe that the findings suggest the need for alternative treatment strategies, including cognitive training and also neuroprotective medication. However, I would also like to highlight some of the main limitations. So we do need further validation studies, especially for the harmonization of the clinical data. And we also, when we retrospectively combine data, we will always lose information. An example was the negative symptoms. And therefore, we believe that it's essential that the field builds a consensus about which variables should be acquired and how they should be collected. In addition, there are some potentially very relevant variables which we were not able to include at all in our analysis, for example, race or also physical health-related factors. And last, we did include ages, relatively wide age range, but I believe it's important that future studies include older individuals with schizophrenia and also individuals at high risk of developing schizophrenia, because we know it truly is a lifespan disorder. With that, I would like to thank all our amazing collaborators for sharing their data and their knowledge, and my great colleagues in Boston, specifically the ones highlighted in blue, who worked on the harmonization of the imaging, demographic, clinical, and cognitive data, and my mentor and the principal investigator of the present study, Dr. Marek Kubicki. I would also like to acknowledge our funding, specifically from the NIMH, and of course, thank all the subjects for participating. And then thank you very much for